The second speaker is Professor Naoki Hiki. He is a professor of surgery, and he is the director of the Department of Gastroenterological Surgery, as well as the director of the clinical nutrition. He is a professional in a lot of fields, including surgical field as well as the research field, and he is a board editor of several journals. Professor Hiki, he is going to speak about preoperative nutrition in gastric cancer. Prof, you have 15 minutes.
Thank you very much, Chairman, and it's my privilege for having opportunity to give my talk to you. But thank you very much. Thank you very much for giving me such a very, very nice opportunity. And my topic is about nutrition. It's opposite side from bariatric surgery. And I would like to talk about nutrition for the long-term survival for the gastric cancer patient. This is our data from a Japanese slim patient and very not so fatty patient, but we have not so many obese patients, but high BMI, we said high BMI is over 25. And low BMI means below 25. I think it's not so fit for your country. But in this data of about 8,000 patients showed low BMI is better prognosis than high BMI patient, and worse prognosis. High BMI is better. I think for high BMI patient, gastric surgery is not so fit, and it's very difficult to proceed lymph node dissection because high rate of complication rate, and then outcome is opposite, and low BMI is worse. This survival rate. And better prognosis in patient with preoperative high BMI. And you think obesity is good condition for gastric cancer. It's not so. I think fat is beautiful. It's not so good. This is next our question. Does good nutrition improve the prognosis of gastric cancer? This is very famous inflammatory-based Glasgow prognostic score for the patient with gastric cancer. We checked up this GPS score. GPS score means point 0 is normal albumin and normal CRP level, and point 1 is high CRP but normal albumin level. And this is low albumin level and high CRP level, point 2. And we compare this point 0 and 1 and point 2. And this, you can see very poor prognosis of GPS 2 point. It means low albumin with high CRP levels. This is overall survival and cancer-specific survival together. And it means albumin is one of the good marker of nutrition. Is very important prognostic factor for the patient with gastric cancer. And this is nutrition for the short-term surgical outcome for the gastric cancer patient. And this is about I'm talking about with complication. A prognostic significance for complication after curative surgery for gastric cancer. This is mortality of the patient, or the patient, and only pathological stage 3 patient, who is very important for the cure for the operative method. And complication plus group showed a very, very high rate of mortality significantly. It means complication is worse than the prognosis. And this is also postoperative gastric cancer inflammation worsen gastric cancer prognosis. This is normal body temperature group, and this is high body temperature group. This is normal white blood cell count, and this is high white blood count cell. Also CRP together. And predictive value of, and I think we should predict this complication preoperatively. And the predictive value of prealbumin is very important. That's why we performed this study, and the predictive value of prealbumin for the complication after gastrectomy. Preoperative nutrition status may have a correlation with postoperative complications. Prealbumin is quickly metabolized visceral protein with much shorter half-life than albumin. Albumin is 2 months, but prealbumin is nearly 2 days. Prealbumin as a single parameter is useful for evaluating protein energy malnutrition, even for the outcome for the just after surgery. For the patient with malnutrition, preoperative enteral nutrition was recommended in some guidelines. And that's why the present study evaluated the level of prealbumin as a predictor of postoperative complication after gastrectomy. The usefulness of preoperative enteral nutrition for patients with gastric cancer. We conducted with patient with gastric cancer for the 1,798 patients, and this is complication rate. And the complication rate according to prealbumin is concentration is showed in this table. And as you can see, complication rate of prealbumin below 15 is about half of the patient. It means 50 patient. And also this 32 and 17 patient. And also infectious complication is also 30% in the patient with prealbumin below 15. That's why we have to prolong the surgical operation, and then we have to treat the malnutrition of the patient with some enteral nutrition. This is multivariate analysis of risk factor for postoperative complication in all patients, and male and prealbumin below 15 and CLP more than 1.0 is risk factor, very important risk factor for the complication. As the prealbumin value declined, the incidence of postoperative complication increased markedly. Male low prealbumin level and high CRP were independent risk factor for postoperative complication. Now, I am talking about nutrition to prevent the complication after gastrectomy. If you find the very low prealbumin patient, how can I do it? And then preoperative enteral nutrition for the patient with pyloric stenosis is very important. If you find pyloric stenosis like this, then we put some nasoenteral tube, and then we perform about 1 week to 10 days of enteral nutrition for the patient. This is a small number of the study, but prealbumin is gradually increased after the enteral nutrition, and the rate of increase of prealbumin is correlated to the duration of enteral nutrition. This is we compare the prealbumin elevation plus group and prealbumin elevation minus group. It means if patient have prealbumin increase more than 10%, it's prealbumin elevation plus group, but less than 10%, then this is prealbumin elevation minus group. Of course, you can see the changes of prealbumin is plus group 52%, but elevation minus group 0. And complication rate is different between these groups. If prealbumin is not elevated, then you can find about 60% of complication, and even in also infectious complication occurred in 40%. And factor involved in postoperative complication, this is univariate analysis, but also prealbumin is significantly correlated to the complication. That's why we prolong the operation, and we do this prealbumin, enteral nutrition to the patient. The level of prealbumin increased significantly by enteral nutrition. The duration of the enteral nutrition correlated with increased rate of prealbumin. Preoperative enteral nutrition may contribute to the reduction of postoperative complication. And prevention of body weight is also important for the in the field of gastrectomy. After total gastrectomy, we always use oral nutrition, but nobody evaluates this kind of enteral nutrition. And this is change of body weight loss after gastrectomy, and this is total gastrectomy, and the maximum body weight loss is about 18%, and then this is pylorus preserving gastrectomy is only minus 7%. That's why body weight loss after surgery is an independent risk factor of also continuation of S1 is neoadjuvant chemotherapy after gastrectomy. It's very important to reduce or minimize body weight for the patient after total gastrectomy. And body weight loss after surgery, it's the total gastrectomy is an important factor also for the prognosis of gastric cancer, as I mentioned. That's why we conducted this clinical trial. We administrate the EPA-enriched enteral nutrition to the patient with total gastrectomy. Primary endpoint was body weight loss of 1 and 3 months after surgery. And this is Consort diagram. We randomized 126 patients in the presence or absence of administration of this ProSure is EPA-rich nutrition. This is relative performance of ProSure. It's before surgery, the patient drink ProSure very well. Median is 100%, but after surgery, median was 50%. This is the main result, primary endpoint. It's I thought patient could drink ProSure very well, but the result was not so good because lean body mass and body weight loss is about 1 month, 553, and also ProSure on off is 54 and 54. No change. And 3 months after, body weight loss was also 51 and 50%. Almost no change. In the presence and absence of ProSure, patient showed no change of body weight. It's sad. I was so sad because of this data. And there is a possibility that the total caloric intake, including hospital meal, was insufficient. Means a patient drink only enteral nutrition. And by performing enteral nutrition via jejunostomy is much better. Significant differences may appear in body weight loss. Further analysis is required on other factors such as lean body mass. It means muscle. Muscle is very important, not only fat, but also muscle maintenance is very important for the patient. That's why we are conducting now a different study with not only nutrition, but also physical examination. And I think next time I can show you next data with nutrition with physical examination. Conclusion, standard diet with EPA-enriched EN didn't contribute to the prevent body weight loss after total gastrectomy for gastric cancer, but further study with physical examination and nutrition would be more and more important. Thank you very much for your attention.
Thank you very much, Professor Hiki, for the valuable information you give us today. And the floor is open for questions. Yes, Dr. Amir.
Amr Shahrani, Aberjan Bariatric Surgeon, Security Forces. I have a few questions.
Yes.
First, how do you explain the pre-albumin level will affect the post-gastrectomy, not albumin? You know, pre-albumin is only reflecting the nutritional status for only 2 days.
Only 2 days?
Yes.
It means pre-albumin.
Yes.
Pre-albumin, if you measure albumin just before the surgery, it means you can evaluate the status of nutritional status of patient before 2 months before the surgery. But if you measure pre-albumin just before surgery, it means 2 days before.
How to correlate the level of pre-albumin, it's low, and
Yes.
the high post-operative complication? Why not albumin level?
Why?
Yes.
I don't know,
Because,
but
as you said, the lean body mass is the most important.
yes.
The albumin is for 20.
Yes, I
21
understand.
days.
And pre-albumin, very interestingly, pre-albumin is correlated to the muscle volume, just muscle volume before the surgery. And pre-albumin is very available to estimate the muscle volume without any measurement of the patient. Also, we have some data of CT scanning, and we measure the muscle volume, and then the muscle volume is just correlated to the pre-albumin of the patient. That's why we check up this pre-albumin before surgery.
Second question, you end by your study that the enteral feeding, it will not increase the, or it will not prevent the postoperative complication. What do you think by TPN? It will not raise
TPN?
Yes. It will not raise the
I think
pre-albumin, and it will make more postoperative.
You know, the ESPEN, European Society of Parenteral Nutrition, Enteral Nutrition, and also ASPEN, American Society of Parenteral Nutrition, recommend that if you can use gut, and you have to use your gut. This is because patient have no bacterial translocation. If you can use their gut,
there is no doubt enteral is better than than what you call it parenteral. But in this case, especially if you are failed to increase the pre-albumin and albumin level, there is no choice to add TPN. From your experience?
No, I don't think so, because the TPN have also infectious complication, and then I think enteral nutrition is nice. If you can put the very thin enteral nutritional tube to the patient. But if you cannot use the enteral nutritional tube...
But now the infection rate is coming down with the new modalities of PICC lines, and the infection is almost...
Yes, I know, but enteral nutrition better. That's why I use always enteral nutrition. And
thank you.
This is my answer.
All right, thank you, Dr. Amir. One question, Professor Hiki, that's it's a continuation of Dr. Amir's question. If you have malnutrition patient and you should build him up pre-op, as you say that the best access to go through and put small nasogastric feeding or whatever. If you fail, what's the next? What's the alternative?
If we fail to getting better to the patient of nutritional status, and then we have to change we have to change the operative method, or we have to put the drainage tube, and then I think also taking care so much.
Are you using interventional technique as enterostomy or not?
No.
No. Are you using TPN?
TPN, we don't use, very rarely use TPN. TPN is not, if you cannot recover the patient nutritional status, then we cannot cure, change the nutritional status, even using with TPN. TPN is, I think, I don't think so, yeah.
Okay, thank you very much, Prof.
Thank you. Thank you very much.